Everyone, my name is Joshua Murphy. I'm with the Health Economics and Epidemiology Research Office called HERO in Johannesburg, South Africa. I'm excited to be presenting some of our preliminary findings on behalf of our study team. Prof. Gesine Meyer-Rath is our local PI here. We'll be telling you about the use of cost data and other economic evaluations in healthcare decision-making in South Africa. It's a case study here. Again, HERO was with Wits in Joburg as well as Boston University. So just a little background about HERO. We've been working on economic analyses of South Africa's HIV and TB response since 2004 in close collaboration with the Department of Health here as well as Department of Treasury. We've added over the years sexual and reproductive health, amongst others, including COVID-19 recently. A number of other academic and nonprofit institutions provide similar data in South Africa. There's increasing need, availability, and opportunity to use costing data in economic evaluations and health programs. With decreasing available fiscus, government and nonprofit organizations are asked to do more with less. We hear that from South African government, and we hear that from international funders. So what were our objectives? What we sought to understand: how have cost data and other economic evaluation outputs been used to make program decisions and implement new interventions? We looked to understand, has HERO and other organizations that provide costing data and economic evaluations, have we asked the pertinent questions or presented those data to the most relevant people? We look for enablers and challenges to the use of these data and what can be learned from the work we've done in HIV, TB, and sexual reproductive health cost data for planning universal health coverage. And when I say universal health coverage, the term we use, well, the program or policy we follow in South Africa is National Health Insurance, NHI. So when I say NHI, for international audience, think of universal health coverage. And also what we can learn going into structures for health technology assessments. It was qualitative in nature. We interviewed 22 users, producers, and users/producers of cost analysis or economic evaluations in South Africa. We did these interviews between February and March. We conducted a thematic analysis. The deductive portion was based on literature from data demand and use, as well as in-house expertise, and our inductive nature came from data that codes that came out of the interviews, emergent themes. Again, here's an overview of our 22 respondents: 6 from government, 12 from the nonprofit organization, and 4 from the universities, and they all covered, they were producers, they created this type of data, they used it, or they were a hybrid combination. The primary findings, these are preliminary findings again, but are in 6 categories. We looked at the process of implementing a new intervention, familiarity with the cost outputs, our organization, HERO, as well as others organizations' contribution in South Africa, factors facilitating the use of these data, barriers to the use of these data, as well as solutions, and how this can be transferred to national health insurance. So what we found in this process of new implementations, the stakeholders were pretty consistent from our respondents. They talked about National Department of Health, including the technical working groups, National Treasury playing a big part, international bodies, WHO, UNAIDS, and PEPFAR, as well as researchers and academics. We considered the criteria that the respondents talked about when they're making decisions was cost effectiveness, outcomes, available funding, saving costs for saving lives. I'm not going to read this whole quote, but what it's saying there, and I think many of us may have experienced the idea of having many stakeholders can make any implementation difficult. So we've got a quote here from a colleague, a data producer of economic evaluations, cost data. talking about the difficulty coordinating the different stakeholder needs of Department of Basic Education, Department of Health, Department of Arts and Cultures, Department of Social Development when rolling out a circumcision program. He ends with the ability to reprogram is difficult and sometimes there is a lack of will. Familiarity with cost outputs. Generally, the knowledge of the outputs, what Hero made and other producers was high and fairly uniform across the respondents. Of course, that may have had some sample bias considerations, considering we were looking for experts familiar with these outputs. The respondents also discussed recognition and reliance on the Hero's costing work, especially a strength in HIV, and there was high self-reported use of cost data for planning, budgeting, cost-effectiveness analysis, and expenditure review. Hero and other organizations' contribution to what's happening in terms of use of cost data and economic evaluations. Respondents mentioned amongst Hero as well as other organizations a willingness to collaborate and share, to assist and problem solve, to adapt to user-specific needs, which enabled users to make informed program decisions. An important quote here, you know, there's always some international consulting company that wants us, South Africans, to use their flippin' model. So I took great delight in insisting that is to be a local institution's work instead. And while many organizations cover primary healthcare space, most focus on HIV and TB and are limited in other data areas. And we have an example from CHI also doing work in the area. Facilitators to use. The respondents talked about the real world costs, make it easier to use, giving a higher level of confidence. Collaboration is a facilitator to use, and focus by Treasury on the investment case and ring-fence funding mechanisms with central control, which we call conditional grants in South Africa, was a facilitator to use. And this large quote, I can let you take a quick look. He's talking about how South Africa has been using more and more of the HIV and TB conditional grant it allows for more controlling of funding by the Department of Treasury, and it's growing outside of HIV and TB to include malaria, and they're increasing the number of conditional grants. And this respondent said, so I think Treasury likes the investment case thing a lot. It gives them a way of controlling the National Department of Health, which I think they also like, and it gets them some way of knowing how their money has been spent. And this is a potential precursor to the NHI benefit package. Barriers and solutions to use. We saw a lot of variability in terms of literacy. There were some concerns there. There was scant access to bottom-up costs and programmatic data. HIV, TB data were stronger, and there was some lack of coherence in communication between National Department of Health and Treasury. We talked about solutions. We learned from the respondents' perspective of the solutions. More leadership, they suggested, as well as technical capacity building of National Department of Health management staff. There was also the respondents also mentioned the importance of up-to-date costing at the most granular level. So from a data producer at the bottom, this was a university-based person. This person said, our teaching program should focus on Department of Health staff because we can't produce the cost data as well as make sure they're used in the appropriate manner. So that's an effort they're doing to build capacity of costing data and economic evaluation literacy. Nearly finished. We're looking now at transferring what Hero has done from the respondent's point of view to national health insurance. So respondents made the following key points. Interventions and services should be prioritized based on burden of disease and quality of life indicators. The majority of respondents said the government should develop a network of academic institutions that will lead the technical work to conduct health technology assessments. There was resistance by most all respondents to specify a single value cost effectiveness threshold. And international models provide valuable implementation. We looked at, respondents talked a lot about what's happening in Thailand as well as the UK. And here are some quotes about transferring those experiences. Just about out of time, but I have a few discussion points that this is preliminary data, so our discussion is being finalized as we speak. So based on our results, we came across some tensions. And tension's not necessarily a bad thing. I think more areas for exploration, as well as perhaps going into the handbook of using cost data and economic evaluations in LMIC, which we hope to be contributing to. So we've got equity versus affordability. That's a tension that goes into the implementation decisions, cost effectiveness versus affordability, as well as national priorities versus international priorities guidelines. South Africa is uniquely placed, as some of the respondents say, as what's happening in South Africa can sometimes influence international policy. Challenges included, and I think I've talked about these in our results, kind of mixed messages. This also speaks to a tension perhaps, relatively high quality cost data, but largely only from HIV and TB programs. So a need to explore and make sure that those data are also available from other program areas, health topics. Variable economic literacy, we talked about that. Some respondents also talked about the importance of getting literacy increased at the facility and operational levels. We'll talk about that on my next slide. And we've got few formalized efforts to improve use of data. Nearly finished. Recommendations: importance of up-to-date costing at the most granular level, increased accessibility and use of cost and programmatic data, link institutions like HERO together to implement HTA, led by the National Department of Health, and following other international models. Further advocacy for high-quality, accessible electronic real-time cost and programmatic data, and continued advocacy of leadership around the use of cost data. So I think we've really collected some valuable insights from these experts, and we're happy to be presenting these data to this audience. Difficult to interact with such a quiet crowd, but you've been so attentive. I appreciate it. As always, we want to recognize funding from Bill and Melinda Gates Foundation under the grant Prospective Costing Exercises for HIV in High Prevalence Countries, and the main recipient under the Harvard School of Public Health. Much thanks to our Harvard School of Health PIs, Stephen Resch and Jora Sortman. We also want to thank our data collection team and all the respondents who took time out of their busy days. Questions can be sent to us electronically, or if there's any means within the conference proceedings, follow us on Twitter. And wishing you everyone well in this difficult COVID-19 climate we're all dealing with. Thank you very much.